Now, you heard from Richard Krakowiak, you heard the vision. What we will do, hopefully, in a few years from now. Now, I will try and give you the feeling of what we can do now in patients to tease out the complexity behind neurodegenerative diseases. So my talk will be on the other end of the spectrum, the vision and the hard life, the hard reality, if you wish. But you will see glimpses of what Richard has been addressing, the need of dissecting out neurodegenerative syndromes which look the same phenotypically, but in reality are neurobiologically different. And the issue of doing this feat for the sake of developing effective drugs, of denoising and developing and building clinical trials on pure groups. I will touch 3 points. I was not ready to speak in 20 minutes, so I will summarize some of them. Some background, some notions on how we can do early and differential diagnosis of the neurodegenerative dementias today, here and now, and some notions on new treatments and pharmacology. Now, first issue that I want everyone to be aligned on is that Alzheimer's disease is not brain aging. So what we are discussing here is not brain aging. We are discussing disease. This is an interesting pathological study showing that the prevalence of Alzheimer's pathology over time, these are a series of brains come to autopsy for a number of reasons, showing that after a given age, 85, 90 years of age, Alzheimer's pathology decreases with age. It does no longer increase with age. It decreases. Why is that so? Well, because other types of neuropathology become more often with advanced age, such as hippocampal sclerosis, but not only. Of course, we have reversible dementias, vascular dementia, and neurodegenerative dementias. Here, this is where I will focus. When we, the current understanding of neurodegenerative dementias, which might be radically revised in the future thanks to the Human Brain Project, but this is what we are, what we believe now, and what we're working on, what we're taking for granted, for the truth, is that neurodegenerative dementias are proteinopathies, are diseases caused by the accumulation outside the neurons or inside the neurons of pathologic proteins. In Alzheimer's, it's beta amyloid and tau. In Parkinson's and dementia with Lewy bodies, it's alpha-synuclein. In the frontotemporal dementias, which are, as you've seen from Richard's slide, extremely heterogeneous. There's at least 3 different molecular pathologies. What's interesting is that, from an applicative viewpoint, is that we are starting to have biomarkers for the molecular pathology. We have markers, we have ligands, PET ligands for the beta amyloid within the synaptic clamps that we can use for diagnosis. In the past few years, people have developed tau ligands for the neurofibrillary tangles of Alzheimer's and for tau, pathological tau in frontotemporal dementias. And these ligands will also be used for diagnosis. that will most likely be ligand for alpha-synuclein and for the other molecular pathologies in the future. The past that we're coming from in the field of the diagnosis of Alzheimer's disease and the dementia is a very, very simple past. These are the criteria, the clinical criteria that we've been using to diagnose Alzheimer's in the past 30 years. And if you, this is a summary of the criteria, but it's a fairly faithful summary. We use it to label Alzheimer's dementia, patients with cognitive impairment, progression, disability, difficulty in daily life, and no other visible cause. So as you can see, there's no hint to any etiology. Based on these criteria, Alzheimer's might be viral, toxic, due to anything, you name it. So this is the reason why, this is the reason of the heterogeneity of Alzheimer's patients, of what we've been calling so far Alzheimer's. When we use more sophisticated tools, when you use more sophisticated tools to dissect the heterogeneity, we found that Alzheimer's is made of a number of groups of patients, not one group, it's not one disease, it's a number of them. At least what we've been calling Alzheimer's dementia. Based on these criteria, what we've been able to develop so far are just symptomatic drugs. Drugs that can sometimes, not always, improve a little bit cognitive symptoms, but in the end, the drugs that are unable to arrest, to halt the progression of the disease. What we've learned in the past few years is that the phase of the disease that we've been diagnosing, that we've been recognizing so far, it's only the last phase of a much longer disease, which goes on in the brain. The stage before the dementia is the so-called phase of MCI, mild cognitive impairment. Before being diagnosed with Alzheimer's dementia, patients who were coming from a phase of 2, 3, 4, 5 years of mild memory problems, but yet no disability, because people were able to compensate in a way. And also, before the MCI phase, we know that there's an asymptomatic phase, which is probably of a 20-year phase, where the pathology, the molecular pathology, develops in the brain slowly, but as Richard was saying, the brain, the resiliency of the brain, the plasticity of the brain is able to compensate for the damage, for the neurobiological damage, and the symptoms do not show up, do not appear until a given threshold of damage is overcome. Based on acquisitions on the natural history of the disease, different clinical criteria have been developed. So the understanding, even at the low clinical level, the understanding of what Alzheimer's disease is, what the neurodegenerative dementia is changing. It's already changing. And these are the criteria that will increasingly be used in the future, developed by European and American groups, showing that, claiming that we can define Alzheimer's disease, no longer Alzheimer's dementia, mind you. We can diagnose Alzheimer's disease in patients with memory deficits and some markers of neurobiological damage or molecular markers, brain amyloid deposition, markers of brain damage such as metabolic changes in the temporal cortex, medial temporal atrophy, neuronal loss, synaptic loss in the medial temporal lobe. And based on these criteria, hopefully, by selecting more accurately patients in clinical trials, we hopefully would be able to develop etiologic treatment. No longer symptomatic, only just symptomatic treatment, but treatments that go to the molecular biology of the disease. Now, what is also of great relevance is that we are starting to understand what takes place. We're starting to understand the dynamics of the neurobiology of Alzheimer's disease in the 3 phases that I just mentioned. And we know, we're starting to understand that the first neurobiological change that takes place even at the asymptomatic phase is the buildup of amyloid in the cortex. And we have biomarkers for that. We can appreciate that amyloid buildup with amyloid PET or with lumbar puncture, and by measuring amyloid in the CSF. After the amyloid buildup, something goes wrong at the synaptic level. And markers of synaptic damage, such as FDG PET, FDG PET is a technique that allows you to appreciate the utilization of glucose in the brain, and glucose is used largely by synapses. So if you find, as in this scan, if you find that in these areas are unable to use glucose, this means that that synapses at this level are suffering. And the next change, neurobiological change, is atrophy, neuronal loss, shrinkage, brain shrinkage, that you can see in some areas earlier than others. And in the areas where you can see the shrinkage is the medial temporal, the hippocampus, where memories are stored, where memories are formed. And tissue loss can also be indexed by tau protein in the CSF. There's a large number of other markers, structural and functional markers of brain damage that you can see here. Some of them developed by Richard and his workers and his co-workers. But you know, the ones that I've mentioned are those that can be used by memory clinics in patients. And you see, physicians are simple-minded persons. They want something low level, but which works. They want to be sure that it works. It must be simple, it must be easy, but it must work. Anything which is extremely sophisticated, but not so clearly useful for the diagnosis, doesn't make physicians happy. So all these wonderful structural and functional markers may become the armamentarium of physicians in the future, maybe, but not today. And this will be the challenge of summary. Now, what we want to do in the study of the neurodegenerative diseases is, after all, something not terribly new. What Richard wants to do is completely new, but what we're trying to understand in the clinical realm is something That's been done in the past in biomedicine for a number of other diseases. I don't know if there's doctors among you, those who have a medical background will recognize this. This is something that everyone studies in the second or third year of medical school. This is the dynamics of the change of biomarkers in hepatitis. There's a number of antibodies and antigens that change from an asymptomatic phase, and a chronic phase, or a healing phase. And physicians have been using these biomarkers for years now to make early diagnosis based on a combination of biomarkers, because you know that in this phase, if you find this combination of biomarkers, you have the disease, and the disease is still asymptomatic. You can use it to stage the disease, to figure out where in the disease course that individual patient is, and you can use it to track the activity, the progression of the disease, the activity of the disease. When you give a drug, you measure the biomarker, you see how the biomarker moves, and you figure out whether the drug is effective on that individual patient. So what we want to do in neurodegenerative diseases in clinical practice is precisely this. So let me show you that this scenario is feasible, is something that can be something real and not only an idea. Now, this is the clinical epidemiology of AD dementia, mild cognitive impairment, and the cognitive normal state. Now, what this slide shows you is that what we call AD dementia is underlined most of the time by Alzheimer's pathology, plaques and tangles, but in a sizable proportion, and this is about 25%, but it can be 30 and up to 30 or 40%. It's not Alzheimer's pathology. As I said, we call it Alzheimer's dementia because the syndrome is reminiscent of Alzheimer's dementia, but pathologically, it's not Alzheimer's disease. It's something else. There's no amyloid. Sometimes there are tangles. Sometimes there's neither amyloid nor there's no senile plaques nor tangles. There's completely other things, and this can be up to 30%. In MCI, in patients who come to memory clinics with memory problems and no disability, you still okay. And the other point is that when you diagnose Alzheimer's dementia, basically you don't see, you always find some neurodegenerative pathology. Whether it's Alzheimer's pathology or non-Alzheimer's pathology, but it's one or another form of neurodegeneration. Now, the scenario is completely different in patients coming to observation with mild cognitive impairment and no disability. Okay, patient coming to you saying, "Hey doc, I have memory problems." You make them undergo neuropsychological testing. You find objective memory problems. Fine. These persons, in about half of the cases, they have Alzheimer's. They have Alzheimer's pathology. In a minority of cases, they have non-Alzheimer's neurodegeneration, but in about half of the cases, they have no neurodegenerative pathology. No Alzheimer's, neither Alzheimer's nor non-Alzheimer's pathology. And from a medical point of view, you understand that this is of paramount relevance, because these persons, the person with a mild cognitive impairment coming to you can be a person who will develop dementia in this case, 2 or 3 years down the road, or will never develop dementia in the next 10 or 15 or 20 years. So the clinical question is paramount. So let me show you how we use these biomarkers. This is going on and on. How we use these biomarkers to figure out the MCIs with Alzheimer's and the MCI with physiological aging. We've studied a group of 70-something patients with mild cognitive impairment coming to observation to 3 memory clinics, one in Italy, the Netherlands, and Sweden. And at baseline, these 70-something patients were all alike. Okay? There was no way, from a clinical point of view, there was no way of telling who would develop, who would worsen, and who would remain stable. They were similar in terms of most variables. They were only slightly different in terms of the MMSE, but this is something that you're not going to use in practice. But when we followed them over time, as I said, about 60% remain stable, about 40% decline and develop dementia. So at baseline, in all of them, we took lumbar puncture, FDG PET, and we measured atrophy of the hippocampus. So based on the progression of the biomarkers that I've shown you, you can hypothesize that these MCI patients will fall into at least 4 baskets. You will have those where all the 3 biomarkers are negative, and these will be those who are here, those where the neurobiology of the Alzheimer's has not even started. They are nowhere near the neurobiology of the disease. You will have, on the other hand, you will have those where all 3 biomarkers are positive. And these are those standing here. All 3 abnormal. And what we saw is that when we followed these patients over time, those whose biomarkers were all negative almost never developed dementia after as long as 7 years of follow-up. Those where all 3 were abnormal, they invariably developed dementia at follow-up. So what this is going to tell you is that these biomarkers can be used now, today, to do early diagnosis of Alzheimer's. However, please.
How is dementia diagnosed? Was it just cognitive impairment, or is it actually histologically validated? Probably not, but just 7-year follow-up. How's the dementia diagnosed? Because it's just a 7-year follow-up, the patients are probably still alive, so they can't do anything histologically.
Yes, well, dementia is a clinical diagnosis. It's not a pathological diagnosis. Okay? Dementia means cognitive impairment plus disability. Okay? So these guys had cognitive impairment at baseline. All of them had cognitive impairment. No one had a disability. Only some of them developed disability at follow-up. Okay? And the notion is that those who develop disability are those with the Alzheimer's biomarker profile those with the biomarker profile of Alzheimer's pathology. Those who remained stable did not show any Alzheimer's pathology.
But that's a hypothesis.
They
They develop dementia, but you still have to show that that dementia is 100% Alzheimer's. It could still be 70%.
Well, yes and no.
It's,
Yes.
it's probable that you've improved the pathological diagnosis somewhat, but it's you're going to need to show by how much.
We do not have pathology in India.
I know.
Okay? We don't have pathology.
I know, but I mean, someone will show.
However, we know that the abnormality of CSF beta 42 is a reasonably good correlate of amyloid in the brain.
I'm not disagreeing with your thesis at all, and I'm not disagreeing that this is an advance. But to get the maximum benefit, you would want to get the full mechanistic diagnosis, and for that you need to either follow up those people and show that they are pathologically Alzheimer's, or show by how much you've increased the precision.
Yes, from a pathophysiological, to better understand the pathophysiology of disease, I fully agree.
And for clinical trials.
And for clinical trials, what this tells you is that the message of this slide is that is one of practical usefulness.
Yeah, sure.
Okay? It's practical usefulness. You can tease out who will remain stable and who will deteriorate.
Yeah.
Of those who will deteriorate, we believe that these will have Alzheimer's and pathology. But this is a hypothesis. What's also interesting is that we found a group of guys, of MCI people, who did not comply with the dynamics of the biomarker abnormality that we believe is typical of Alzheimer's. So either these did not read our scientific papers and they behaved in a bizarre way, or they have something different. They are on a different track, on a different track. And we have studied these guys in greater detail in a larger data set, and we found that these individuals, they have signs of neurodegeneration, atrophy on MR, and hypometabolism on FDG PET, but they don't have amyloid. So, and they are called SNAP, suspected non-amyloid pathology, meaning that they have something which is going on in the brain, something bad which is going on in the brain. But that's not Alzheimer's. And as you can see in the next slide, the incidence of deterioration over time is intermediate between those who are positive to all biomarkers and those who are negative to all biomarkers. So it's probably it's a mixed bag. It's a mixed bag of a number of different neuropathology that we know pathologists have seen these pathological pictures in the brains of people whose phenotype we do not know. So what we are trying to do is to figure out what's the phenotype, the clinical phenotype and the biomarker phenotype of these pathological changes. And this is precisely one of the aim of the Human Brain Project. So I believe that my time is over, and just to the very final slide. The very final slide is to show you in practice the relevance of developing clinical trials with pure groups. This is a clinical trial in MCI patients carried out 10 years ago. Okay, 10 years ago, a guy came out with this paper saying, hey, I have seen patients with mild cognitive impairment, and I believe that this is early Alzheimer's disease. Great. Early Alzheimer's disease, we define We take these people and we treat them immediately to delay the progression of cognitive impairment. Well, so they set up this large clinical trial where MCI patients were treated with placebo, donepezil, and vitamin E. The result? No effect. All three groups developed dementia with the very same incidence. However, what they found is that a posteriori, so the trial was failed, closed. Okay, donepezil was never approved to treat MCI patients. However, what they found a posteriori is that the MCI who were progressing were the ApoE4 positive, and those who were not progressing were the ApoE4 negative. In those years, they did not have the biomarkers that I've shown you. But we now know that these ApoE4 guys are the biomarker positive, and the non-ApoE4 carriers are the biomarker negative. So if these guys had been able to differentiate these two groups at the very beginning of the trial, not after the trial was completed, they might have found an effect. And indeed, what they found is that only the ApoE4 group, in the ApoE4 group, there was a delay of the incidence of dementia in the treated versus the placebo of about between 6 and 12 months.
I was just wondering, has it now been replicated? Because as you said, this is post hoc now.
No, it's no longer being replicated because the concept of MCI has never taken ground with regulatory agencies for this reason, because MCI is not a disease, it's a syndrome.
But now you could combine the biomarkers you presented and then have another trial.
Exactly, and this is what people are doing. This is what people are doing with monoclonal antibodies. The clinical trials that are currently in place with monoclonal antibodies against beta amyloid pre-select patients based on biomarkers, based on amyloid positivity. And this is exactly what people are doing right now. This is a study where with an old design where the patients were included without regard to biomarkers, and still they found some evidence of effect, of efficacy. So the hope is that by replicating this trial, which is currently what drug companies are doing, by replicating this trial, by selecting patients based on biomarkers, this signal will become much larger and more clinically meaningful.